Alrighty, I think we have a quorum, so I'll go ahead and start here. Good morning, everyone. I'm James. I'm going to be leading Neuropath for this month. So we'll go ahead and dive into the first case. Iggy, you can hear me and see the screen, correct? Right?
Correct. We can hear you and see the screen.
Fantastic. All right. So, all right, case one. Case one is a 68-year-old male, Dr. Morkos is actually, with no past medical history, who actually presented with about a year of subtle altered mental status changes. His family said he actually was a very high-functioning individual, and then over the year, he just started being a little off and peculiar. In the last few months, they noticed he was having some vision difficulties. They had a family history of Alzheimer's, so then they went to see a neurologist who recommended an Alzheimer's workup, which included an MRI. His neurological exam was intact, except what the following imaging will show, and I kind of want to see if someone could see what the physical exam finding would be. So who do we have? Damien, are you available, boss?
Yep.
All right, fantastic. All right, so here's the MRI. Tell me what you see, what cuts, what sequences, and then after that, tell me what exam finding you would expect.
Sure. So it's a MRI in the top left, the T2.
Mm-hmm.
Bottom left looks like a T1.
Mm-hmm.
And the middle two look like flare.
Correct. With contrast,
larger
without contrast?
With the L looks without contrast.
Correct.
So there's a large cystic lesion in the right occipital lobe, so I'd expect a left homonymous hemianopsia.
Excellent. Yeah, and so what is the flare showing you?
I mean, the surrounding edema of the lesion itself.
Exactly.
But it doesn't look like there's that much edema. It looks like it's mostly cyst.
Exactly.
Compared to T2.
And so what else would you want to see? What other sequences would you want to see with this?
Contrasted. All right.
So here's a contrasted, and see if you can kind of put more descriptors to it and what sequences and cuts we're looking at.
Sure. This is a sagittal axial MRI with contrast, showing a like multicystic heterogeneously enhancing lesion in the right occipital and upper occipital lobe.
Correct. And so if you kind of throw like a term on it, we would call it a ring enhancing lesion, no?
Yeah.
So what's your differential for ring enhancing lesions? This is one of those things we get all the time at morning conference. Metastatic lesion, in GBM, abscess, toxo, like infectious ones, lymphoma, I guess could probably do it too. Perfect. And so based on what the ring enhancement looks like, what would you say is the highest in your differential? A guy with no other past medical history, who's just had progressive altered mental status, and you were right with the physical exam finding. He did have a left homonymous.
It looks like probably a GBM.
Yeah. Okay. So next, so what's your plan? I'm assuming you're going to say resect, but what considerations would you have in terms of, in particular, positioning and where would you enter these tumors in general? This is kind of just general school of thought for tumor surgery.
I mean, you'd want to kind of traverse the least amount of normal brain possible to get into the tumor. But it also can, approach it sort of on like the long axis, so it gives you the most access to, the entire tumor. You'd want to try and get out as much, if not all, the GBM as you can. I think you could in this case. It's on the right side, so you're less concerned about, kind of like left superior temporal gyrus and kind of left temporal lobe, dominant temporal lobe findings as you get more anterior. And then positioning. You probably need like a pretty large bump if you wanted to do it supine, or you could consider doing it like in a lateral, lateral right side up as well.
Well, going along what you said, going along the long axis of the tumor, and you see on this sagittal cut, kind of the most portion that comes right to the surface is that portion near the occipital, superior occipital pole. Working down the long axis, would you consider doing it like a prone?
Yeah, you could do prone as well. I think that's also reasonable.
Okay, perfect. So you hit all the points, some of the points that we're going to talk about. So yeah, that's differential, just like you said, and the operative plan. So this patient underwent a right-sided cranie, right occipital cranie, actually in the prone position, so they could look down that long axis. And when they got intraoperatively, they saw that it was obviously large. It was cystic, just like you had mentioned. It was reddish gray in color, and it was very infiltrative. So it looked gliomatous in its intraoperative qualities. So it's Dr. Gultikin around.
Yes.
Perfect. Hey, sir, I have your slides already built in here, so I can just move on to the next.
Start with the first one.
Perfect. So here's the first slide.
So here you see on the left a typical malignant glioma infiltrate with large pink cytoplasm. Some of them look hemistocytic, infiltrating through the background parenchyma. On the right side, you see the typical telltale necrotic pattern that is often seen in high-grade gliomas, especially glioblastomas. It's called palisading necrosis. That means the center is necrotic on the right side, and it is surrounded by an intensified, number of tumor cell nuclei. If you compare the perinecrotic density, tumor cell density, it is a little higher than the regular tumor cell density on the left. So that's called palisading necrosis. Okay, so this is a glioblastoma with high hypercellular, atypical astrocytic proliferation plus necrosis. The interesting thing about this one was there were some areas that looked a little different. See this nodule between the blue dots on the left? Yeah. On high power on the right, you can see that this is a little different from what I showed you first in the first slide, in that these cells have darker nuclei. They have more primitive, almost a PNET-like, primitive neuroectodermal tumor-like differentiation, rather than immediately being recognizable as glial cells. So this is a variant of glioblastoma. Exactly, yeah. So it was IDH wild type and focal PNET-like component. The practical importance of this is, it may give you a diagnostic difficulty if it's the predominant pattern. Also, these patients apparently have a higher chance of having CSF seeding. Okay, that's why this histological pattern is mentioned in the report. Otherwise, it would be just a semantic, detail. Okay, that's all I have for pathology on this patient.
Perfect. All right. So just as a quick cursor in the GBM school. So GBMs, as we know, the most common primary brain tumor. They're the most malignant astrocytomas, and they tend to be supratentorial. In terms of the types that we'll find, there's two main types. The most and the lion's share of them are called de novo, meaning like in this case where they come from apparently nothing. And then there's also the secondary kind, which is a patient who had a lower grade glioma that over time has transformed into a high grade glioma like a GBM. So these are some of the pathologic findings that Dr. Gultikin talked about, the palisading necrosis, as well as these glomeruloid structures that you'll see.
Glomeruloid structures are blood vessels.
Oh,
so
okay.
Somebody needs to clarify this, right? When you say glomeruloid structures, they look like glomeruli of the kidney on the left, but they're actually, this is called vascular endothelial proliferation.
Okay.
And this is one of the histological criteria that may make a glioma, an astrocytoma, a glioblastoma. Either vascular proliferation or necrosis would make an astrocytoma glioblastoma. Okay.
Okay. And just in terms of from a surgical perspective, there are a few studies along the way that have kind of helped teach us about how to best treat these patients and manage them. And in particular, out of the MD Anderson with Dr. Sawaya's group, they published that a significant survival advantage was associated when you got 98% or more of the tumor, where compared to getting less than 98%. And that was a median survival of 13 months versus 8 months. Then the UCS group with Dr. Berger said that they did in fact saw that there was some survival benefit when you hit as little as 78% of extent of resection. That's what EOR stands for. But then as you increase that extent of resection, that there was a stepwise improvement in survival, especially when you got to that 95, 98%, which is similar to the Sawaya paper. And then our group out of here actually showed that with that the survival benefit for patients undergoing lobectomy was even better, 30 versus 14 in progression with the lobectomy, and with progression-free survival also being improved. So then that's surgical. And then this is something that we hear about all the time. The Stupe Protocol was actually a very important paper. It was published in the New England Journal. And it showed that the 2-year survival rate in patients treated for GBM with surgery, they looked at a group with just radiation therapy and then radiation plus temozolomide. And they saw that those with temozolomide, in addition, had a 26% higher 2-year survival rate. And this is the Stupe Protocol, where it shows that you get, the 6 weeks, the first up front, you get the 6 weeks of treatment, daily radiation, temozolomide, weekends off. Then you have that after 4 weeks of that. After a break, you then do it with cycles, with temozolomide interspersed within there. And that New England Journal paper, the Stupe Protocol, these are the two graphs showing improved overall survival and progression-free survival in the two groups, comparing the two groups. And just to touch briefly, as Dr. Gultikin had, is that when we say GBM, we think of GBM as a whole, but as molecular markers and pathologic advances continue to happen, you start seeing that there's different variations. And one of the ones that was seen in this case was GBM with the PNET. And just, I'm not going to reiterate everything you said, but there is a higher predisposition for CSF seeding. And there's other variants as well, and that's shown right here on the left. So second case, let's see. So second case, patient Dr. Levy's, 68-year-old woman, history of chronic rheumatoid, who has been on methotrexate and as well as prednisone for these flare-ups, who actually presented for lower extremity weakness and balance problems for about 6 months. Her husband was a neuroradiologist, so she got all the imaging that you can imagine, but in particular, the MRI showed that she had some diffuse bilateral white matter disease throughout the brain. On exam, she was actually neurologically intact. She's elderly, she's frail, but she was full strength and had no signs of myelopathy. So let's see who we have. Turkey, are you around? Okay. Adham, you around?
Yes, I'm here.
All right, perfect. All right, so so this is the patient's history. What else would you want to do? This I'm talking before surgery. So you have a patient with lower extremity weakness that has white matter disease on brain imaging. What would you want to do? And they're full strength on exam.
And you're saying she has a rheumatoid history, like
Correct.
Okay, and is it flaring up or is it managed? Like, do we need
she's on methotrexate, and I think it was prednisone for flares.
Okay.
Kind of think like a neurologist is what I'm trying to get you down.
Yeah, and they did EMGs already.
Actually, I don't remember if they did EMGs. But I think if we boil it down to bare bones, white matter disease in an elderly patient who's complaining of weakness and imaging findings of white matter disease, one of the considerations would be like a lumbar puncture. And so this person actually did undergo an lumbar puncture. They actually went 3 total. And on the third one, it did show that there was increased lymphocytes. Another thing that was in consideration was, could this patient have, sarcoid? You always have to consider sarcoid way in the back of your mind. And do you know what the study is for sarcoid, what you check for, CSF versus serum? I think I'm kind of giving it away too.
No, I'm not aware.
Well, it's ACE. You check the ACE. And so she had a negative CSF and serum ACE test, and also had a negative PET scan. So she got an MRI of the spine. And tell me what you're seeing here. I'm showing just a portion of the spine, and I want you to kind of tell me what sequence cuts and what you're seeing.
So you're seeing on the left the sagittal cut, and you're showing like level L4, L5, L5S1, and then on the right side you're seeing the axial cut of the same level. I think you're, I'm not sure which one you're showing here.
Sorry.
Images like.
It's not the best, even the best MRI. So the left, like you said, is that it's showing the levels of 4.5 and 5.1. It's a parasagittal view. As you can kind of see the pars, the facets, and the foramen. In particular, it's a T1 with contrast. And what I was trying to show is, I don't know if my cursor is showing here, but down in the sacrum, in the canal, you see this white kind of not lobulated, but white mass, enhancing mass down there. And in the axial, you see that same thing right near the S1 nerve root, right? And it's right under the S1 lamina. Okay. All
yep.
Right. So differential for this. Think spine tumors.
Yeah. So you're looking now at an extradural lesion at this point. So it could be a bony tumor. It could be a met. Those will be high. I think you were mentioning earlier that you were considering had high the sarcoidosis markers were high.
They were actually negative.
They're negative? Okay.
Yeah, negative. Yeah.
Yeah, I think those would be the high things on my differential.
Okay. Cool. Yeah. So MET, obviously, anytime you're in the spine, think of a nerve sheath tumor, but this doesn't look like that at all. And then, like you said, metastatic, but also adding to that, potentially sarcoid, and then lymphoma. Okay.
Yeah.
So how would you get to this lesion? I'm showing you that T1 cut, and then the sacrum. The sacrum's not something we deal with too often. Obviously, we know like our S1 screw trajectories and know how to do like intralaminar work there, but the sacrum is kind of, as you know, 5 fused sacral vertebrae. It has its foramen, but based on where the sagittal is, where do you think the lesion is, and how could you get to it?
It looks like it's a S1 at this point. I would assume you're trying to get to it posteriorly.
Correct. Okay. It's a good start. Yeah. So here, I don't know if that helped you a little more. So yeah, you would exactly. So the biggest thing I was trying to get at is that, yes, it's mostly within S1. It's not like higher up. So I think I have a little marker that's showing right around where it is. So it's right in this area where the red box is, on the right side under the S1 lamina. So how would you, obviously we need to go in and get a biopsy of this lesion, right? So here, what was done was a right-sided MIS tubular L5S1 laminectomy. It was really a S1 was the lion's share of the work there. And once we took down that lamina, underneath in the epidural fat area, there was this grayish brownish tissue that was infiltrating the fat. And now we'll go to the pathology.
So on the left, you see the intraoperative frozen section consultation touch prep, and it shows uniform, round, nuclei with not a lot of cytoplasm, kind of reminiscent of lymphoid cells or mononuclear cells. There is no evidence of granulomas here or any epithelial tumor like carcinoma, etc., ependymoma, or etc. So on the right side, you can see what you described on the right side of right picture. There is some highly cellular process infiltrating fat. Those white round spots are epidural adipose tissue. Okay, next slide, please. Okay, on high power, we do see that indeed these look like a proliferation of mononuclear cells. Looks like some kind of hematopoietic process, probably lymphoma. It looks low grade because it doesn't have a lot of apoptosis or many mitoses, etc. On the right side, indeed, we demonstrate that these cells express B-cell markers, CD19 or CD20. In this case, it expresses both of them. So it is probably a low-grade B-cell proliferation. Next. And morphologically, it had some plasma cell-like features. So you can demonstrate a subpopulation of plasma cells with CD, actually it's not C, CD138, which is a plasma cell marker. And then you can show clonality of that with doing kappa and lambda light chains. And if it's positive with one and negative with the other, you can show clonality. So it looks like a low-grade, again, lymphoma, and this is becoming a subspecialty issue now. We sent it to hematopathology, and they classified it as a extranodal marginal zone lymphoma. So the patient is immunosuppressed. Definitely, they can develop lymphoma. Go ahead.
So yes, just like Dr. Gultekin said, that the diagnosis was extranodal marginal zone lymphoma, and just kind of like dusting those neurons from back in med school. It's also known as MALT lymphoma, mucosa-associated lymphoid tissue. It's very interesting. So some of the things he's already mentioned. So it's like a slow-growing non-Hodgkin's-like lymphoma. Most commonly, when we hear it, we think of it under the term gastric MALT because it tends to involve the stomach. But anywhere else, it's called non-gastric MALT. And it develops from the B cells, like Dr. Gultekin was saying, in a region at the edge of the lymphoid tissue called the marginal zone, where they kind of proliferate and come from. And in patients with non-Hodgkin's lymphoma, it's 8 out of every 100 patients will have them, and they tend to fall into some of the demographics of our patient. So 6 years old, obviously she was immunosuppressed. It's not that she had lymphoma. She was 6 years old. It has a slight female predominance, and it was common in those with autoimmune disease, like she had rheumatoid arthritis. And in terms of like neurosurgery stuff with that, you actually didn't see it too often. I tried to find any other studies or anything like that. I didn't find anything super relevant in regard to neurosurgery and extranodal marginal zone lymphoma. So let's move on to the next case.
Just a quick question, James and Dr. Gultekin. So, you saw her MRI of her brain, and she had, positive lymphocytes in her CSF, maybe lymphoma in her CSF. So is this both intradural and extradural? Like, this is not CNS lymphoma. And I asked that because the assumption is that, she has like the changes in the brain are related to her lymphoma. Would that be a correct statement? Because you're saying it's gastric and it's extra spinal sort of, or extra CNS.
So from the stuff that I had seen with this, anytime it was seen in nervous related stuff, I saw some like uveitis. Obviously there was one that involved like the gastroc, like calf muscles, but from like perineural in that case, but nothing that I had seen intracranially. But I'll be honest, I didn't go searching for that.
So Dr. Gultekin.
Yes, I will answer too. I believe this is a good point. I think this is extra neural process. I don't think that the changes in the brain, which I haven't seen, the white matter changes described here have anything to do with lymphoma. If they had anything to do with lymphoma, this would be a very complex issue. It could be a paraneoplastic demyelination, or since the patient has rheumatoid arthritis and was on immunosuppressants, PML would be considered, or it could be even a completely unrelated vascular-based white matter disease. But this would be my differential, but not lymphoma.
And the white cells that we're seeing in the CSF on the third tap, you think are unrelated?
I mean, depends on what kind of white cells they saw. If it was, it may be a difficult diagnosis because these are low-grade lymphoma cells. They may not appear obviously malignant on cytology. I'm not sure how to tie these two things. Since the patient has rheumatoid arthritis, there may be some, inflammatory element in an autoimmune patient you can see sometimes.
Awesome, thank you.
Yeah.
All right. Case 3 is actually a 59-year-old female who presented to clinic actually a few years back. This is more of a follow-up. She's recently sent in clinic for worsening low back pain and intermittent left lower extremity radicular pain. It started in the left hip, it traveled down the left lateral thigh and went to the lower leg, to the lateral aspect of the foot. And now she had associated constant numbness in those areas. In terms of her symptomatology, it was 80% back, 20% leg pain, and she had no right-sided symptoms. But she did have a distance-limited gait of about 100 feet due to the pain, and didn't have any weakness on exam and was neurologically intact. So we have Davik, you're on?
Yeah, I'm here.
All right, perfect. This is all you, man. So here's the MRI. Tell me what you're seeing, sequences, cuts.
Yeah, so on the left side there, you're looking at a T2 axial sequence that demonstrates the T2 hypointense lesion on the left side that's encroaching through the foramen, would be causing a root compression. Similarly, you have a T2 sagittal on the right side there, demonstrating the same finding. Looks like it'd be at roughly L3 at the L3 level, if I'm reading that correctly. 3-4. Okay.
Yeah, exactly. So, any other sequences you want to see?
Maybe a T1 post.
Yeah. So here's that T1 post axial, and what do you see?
So similarly, you're looking at an enhancing lesion. Same thing, emerging through the foramen, well circumscribed. It's working on the vertebral body, displacing the cord to the right as well.
Not the cord at this level, but yeah.
The thecal sac, sorry.
Exactly. And it's kind of like involving or obliterating that whole lateral recess area down there at the 3-4 level. So what additional, when I say workup, I mean imaging studies. So obviously the plan here is going to be to go for surgery in some point, but just you got to kind of think what kind of other information do I want that's going to help me kind of with characteristics of the tumor / with operative stuff.
Maybe about a CNT spine as well. Maybe a CT scan.
Yeah.
Look at the bone quality.
CT scan was what we were getting at. And what are you seeing here in the CT scan?
You're looking at something that's obliterating the left pedicle there. And it's been causing bony destruction. So it's an expansile lesion.
Yeah.
Oh, you're watching Grand Rounds. No.
All right. And so what's on your differential?
I mean, my differential for something like this could consider like a nerve sheath tumor, so a schwannoma, maybe a meningioma, possibly a fibroma, though maybe not likely.
Okay. So do you think this is extradural, intradural, extramedullary, intramedullary? What do you think?
Based off the appearance, it looks like it was extramedullary, possibly intradural.
Yeah. Nice. Okay. Perfect. So, plan. What would you want to do?
Yeah, with
So
this
you
sort
need
of
to,
thing,
you need to take it out, but
I would plan for maybe like a left L3 transpedicular decompression. And then yeah,
let me see if I can show you some of the images. So what's on this left image here, right dorsal to the tumor? What is that an anatomic structure?
would that would be the facet, right?
The facet, right? So in order to get best visualization, you're going to have to take down that facet, right? And so anytime you take down a facet, that means you have introduced instability. So you have to fuse, you have to instrument, right? So that was one of the operative considerations. And so, yeah, you're right. So really just focusing on that 3-4 level, right? So the patient went to the OR, had perc screws done at 3 and 4, and then had like a left-sided mini open approach where the facet was taken down for the tumor resection. And I'll go ahead and let Dr. Gultikin talk about the pathology here.
Well, the big image on the left background represents a moderately cellular proliferation of uniform cells with some visible cytoplasm. From a low power to an accustomed eye, this looks like a meningioma. It doesn't have any telltale like samoma bodies, whorls, etc. But sometimes meningiomas do this. They just simply have a sheet of cells without any of those other attributes. On the right side, you see the white part is the fat again. So this tells a pathologist that you're out of the dura, epidural at least. So same thing happens in the cranium. When the meningioma goes extracranially, you can tell by the type of tissue that you guys give us that there must be some extra, dural extension. It could be bone, it could be fat, it could be fibrous tissue, etc., other than the dura. So, and you can see islands of tumor cells in this picture. Next. So there are some features here that I'd like to show. First, at the top two slides, you can see some higher density cellularity areas, foci of hypercellularity. On the left lower picture, you see cells with more prominent nucleoli. I don't know how the picture projects, but you can see these blue dots inside the nucleus that is visible from a lower power. So we call that prominent nucleoli. And I was able to also find an area of necrosis, a single small area of necrosis on the right lower picture. Is that the last slide? Next, yeah. So there was 1 or 2 mitoses, not really high mitotic index. It is positive with the best meningothelial or meningioma marker, somatostatin receptor type 2A, which really stains all meningiomas, even atypical and malignant ones. Other markers for meningioma would be progesterone receptor and epithelial membrane antigen, which I'm not, actually I'm showing the progesterone receptor at the bottom, which is focally positive. It's a nuclear marker. The Ki-67 was generally lowish, but there were some pockets of slightly higher Ki-67 index. So it's a meningioma. How did this patient do? Did she recur?
So patient had done really well. She lives actually internationally and has been coming back for radiologic follow-up. And so I think I'll get to that at one point.
Okay.
Just 1 second, Dr. Gultikin. So yeah, it's interesting because that lesion kind of extended out of the frame and it kind of slowly just modeled the bone there. It looked kind of schwannomy, and it sounds like intraoperatively from the operative record that it would look to be kind of like a schwannoma. So the pathology coming back as spinal meningioma was, a surprise. So just some info on that. So peak age is between 40 and 70 years old. It has a female predominance, 4-to-1, but in the lumbar region, it's 1-to-1. It's 25% of all intradural extramedullary tumors. And most commonly, they're actually seen in thoracic and cervical spine and lumbar spine, least commonly. WHO grade 1 variation is called the meningothelial variant. And recurrence rates, even with complete excision, is 7%. And it usually occurs between 4 and 17 years post-op. And so just a couple of more things on the meningiomas, like Dr. Gultikin had talked about the elongated sheets of cells, the psammoma bodies.
Can you go back
that,
one slide, please, James?
Yes, of course.
Yeah. So most are benign. That's the fifth bullet point there.
Mm-hmm.
WHO1, 70 to 90%, that's fine. But I don't understand this meningothelial variant, because there are many variants of meningioma that can be a grade 1. Psammomatous meningioma and other types of meningioma, so fibroblastic meningioma, secretory meningioma, they can all be easily grade 1. So I think there shouldn't be a misunderstanding that the only WHO grade 1 tumors are the meningothelial variant. That's not correct.
Are they the most common variant of
Yes,
the WHO grade 1s?
Meningothelial is a common variant. Depends on the location. For instance, in the skull base, we frequently the fibrous meningioma or fibroblastic meningioma, but overall, meningothelial would be a common variant. Yes.
That's what I was getting across at that one.
Okay.
And some of the markers, you talked about the SSTR marker being a great one for meningiomas. So yeah, just in follow-up, I think now the patient's about 5 years out from surgery, and she was saying she's asymptomatic, she's doing well, just for routine radiologic follow-up, and we did note to have recurrence in the operative bed, and you can see it here, David, right near where kind of where it was before, at the level of this cuts at the level of the foramen, and obviously there's some artifact now because of the instrumentation. So she's clinically asymptomatic, so we're going to watch her and just have another scan and see how she does from there.
Yeah, I mean, this was this must be an old case then. We did her 4 years ago, something like that. Yeah, I mean, we just extradural meningiomas are very uncommon. I don't know how many I've seen, but there's very few. We just did a case yesterday that may have had an extradural component, but was intradural. But Dr. Falcone was telling me, and I assume is true, is that the extradural variants of meningiomas are more aggressive. And that seems to be what you're saying as well here. Does that all make sense? Definitely.
This case should probably be treated as a, potentially an atypical meningioma. I hadn't seen this case 4 years ago. I had the first chance to look at the slides, when I was preparing this lecture. So I think there are some elements there that may herald, an earlier recurrence. So there you are.
Got it. Thank you.
All right. Of course. Next case. Turkey, are you around?
I am.
Perfect. All right, my friend. So here's a case, 84-year-old female, history of breast cancer, was having actually double vision, was seen by a neuro-ophthalmologist, and got an MRI. On exam wise, was neurologically intact. Obviously we're going to need imaging. So here's the imaging for her. Tell me what you see. Sequence, cuts, and describe what you're seeing.
Yeah, so this is an MRI, axial and sagittal with contrast. I can see that there is a multiple enhancing area of the cerebellum and the right middle cerebellar peduncle that goes to the facial colliculus. I guess there's like no facial weakness, right?
No.
Okay, so double vision could be explained by the abducens nerve palsy, given the close proximity to the nucleus on the right side. I don't see any other lesions, just the cerebellar lesion.
Yeah, exactly. So there's actually a few cerebellar lesions, just like you mentioned, a few cerebellar lesions. So 85-year-old lady, history of breast cancer, multiple enhancing cerebellar lesions. What's on your differential?
Yeah, so first is metastatic disease, especially if it's multiple. Least likely is, infectious etiology, such as abscesses. Could be also lymphoma / leukemia. That's that's the most common differential I think of.
Yeah, exactly. You hit the ones we're getting at just in general. So what's your plan for this? What do you think you need to do for this patient? Take out the whole cerebellum or?
Yeah, so she definitely needs, some sort of diagnosis to make sure if it's truly metastatic disease or if it's, other differential. So in her case, the right middle cerebellar peduncle lesion, I don't think it can be safely resected fully, given the location. So just biopsy it and see what kind of tumor that is.
So you're saying biopsy? Would you do
biopsy,
biopsy, needle biopsy, or?
Yeah, I would do, ROSA or needle biopsy.
Exactly. So that's under what the patient underwent. I don't know why the slide didn't show. Underwent a stereotactic guided needle biopsy, and here's the pathology.
Pathology is a bad surprise. As you can see here, rather than the expected metastatic diagnosis, we have a glioma, and this is sort of an amorphous proliferation of glial cells with a good example of palisading necrosis in the center bottom of the left slide, with the center necrotic and the perinecrotic areas have a higher density of tumor cells. That's why it's called palisading necrosis, to repeat myself. And there are mitoses on the right side with the red arrows. I indicate 2 of them. 1 and the 2 is a little bit more difficult to see. So glial proliferation, mitotic figures, necrosis is equal to glioblastoma. And it was beautifully positive with glial fibrillary acidic protein, which is our main marker for histological diagnosis of glioma, meaning differentiation marker. P53 was also positive. Additionally, all the breast cancer markers, keratins and GATA3 were negative. So this is unfortunately a glioblastoma, a rare one because of the location.
Yeah, so cerebellar GBM grade 4, just like Dr. Glutikin's saying. So we're not going to rehash all the GBM stuff from before. We're just going to kind of hone in on just posterior fossa GBMs just quickly. So as we know, and Turkey did a great job, you hit all the differentials, common things being common, and this was that one other thing, cerebellar GBM. So they're, of all GBMs, which are obviously not super frequent tumors at large, but for us they are, of them, they're only about 0.4 to 3% of all GBMs. And it's unusual to have them, especially in adults, because posterior fossa lesions, they're just kind of what you mentioned, Turkey. So Mets, a couple other things, hemangioblastomas, meningiomas, schwannomas. So the question is, well, how did these things all of a sudden come about? And there's a couple schools of thought. Some thinks that it's from if someone has a prior supratentorial GBM, that there's some like seeding via the CSF. But then there's patients like this who have no supratentorial tumor that was detected. And even if you look at the literature, similar cases like this where they have no supratentorial lesion, but they come in with these kind of lesions in the posterior fossa. And in particular, some of the imaging characteristics are slightly different. Like that first case was a slam dunk ring enhancing lesion. You don't too often see that in posterior fossa GBM. So it makes the diagnosis a bit harder from a purely radiographic perspective. And then the question is as well, so since there's no supratentorial lesion, then it has to originate from the glial cells within the cerebellum itself. So it's obviously a super rare tumor and not a lot of them of it. So there's a lot of still research and data coming in on kind of just the epidemiology, the pathophysiology, and even just the imaging criteria of it. So good job, Turkey. And I think that may be everything. I think that's it from me, Iggy. Yeah.
All right. Thanks, James. So we'll move on to my part of the grand rounds today. So for my talk, Josh gave a great talk about ischemic stroke a couple weeks ago. So I thought it'd be appropriate to kind of round out the discussion today of stroke with a talk on hemorrhagic stroke, and hopefully this will cater to a broad audience and be a good review for the juniors, as well as we'll talk about some new frontiers in research and how we're managing these patients. So some epidemiology. Stroke, very common, 15 million strokes worldwide each year. It's the third leading cause of death. And if you look just at the US, it's actually the leading cause of severe disability. So obviously a very large burden on society and on our healthcare system. We in neurosurgery deal mostly with hemorrhagic stroke, so it's easy to forget that the vast majority of strokes are ischemic, so 87%. The smaller slice of the pie is hemorrhagic stroke, so 10% in ICH and 3% subarachnoid hemorrhage. So looking just at that slice of the pie, that hemorrhagic stroke that we're talking about, even though it makes up a smaller proportion of overall strokes than ischemic stroke, the morbidity and mortality are very high. So the mortality is higher than for ischemic stroke. 30-day mortality for hemorrhagic stroke is around 40 or 50%, very, very high. And among those survivors, just 20% end up being functionally independent at 6 months. Looking at the economic burden and the healthcare burden, we're talking about $4.1 billion in annual costs. So clearly a major disease category that our healthcare system has to deal with. Stepping back, looking a little bit about the history, which is kind of interesting. As far back as 3000 BC, the ancient Egyptians actually first described anatomically an intracranial aneurysm. They didn't obviously at that time understand the pathogenesis or the clinical significance of it, but they actually describe it as far back as 3000 BC. Fast forward several thousand years, the ancient Greeks started to get a sense of our modern idea of stroke. They describe something called apoplexy. The description is interesting. They talk about patients becoming drowsy and senseless, and their life expectancy was very poor, as expected. So generally does not reach the 7th day is what was written. And at that time, it was considered impossible to cure. So they clearly recognized that this was a very grave diagnosis. And so again, this is many years ago and already an early understanding. Then the Greek physician Galen, he's someone who just kind of tried to get at the pathogenesis of it and described something called the accumulation of phlegm. And that was his explanation for what these apoplectic events were. And then it really wasn't until the 1800s when the French physician Rousseau actually kind of had the first modern description of stroke. So saying that apoplexy is a hemorrhage of the brain by rupture with more or less serious alteration of its substance. So it's really remarkable that really it's only been about 200 years where all of our understanding and treatment of stroke has come from, and many thousand years before that not much was accomplished. So looking at risk factors for hemorrhagic stroke in general, older age, male sex, and this is specifically for patients under 65. This is not true for older patients. Smoking, the peripartum period. The Asian and African-American populations tend to have a higher rate of hemorrhagic stroke, hypertension, as would be expected, anticoagulant use, cerebral amyloid, and dialysis. So we can break down hemorrhagic stroke into two major categories. One is primary intracerebral hemorrhage, which you can think of just as basically not due to a vascular etiology or does not have a vascular explanation for it, whereas secondary intracerebral hemorrhage does have some sort of vascular or iatrogenic explanation for it. And I'll go through each of these over the course of the talk. So we'll start with cerebral amyloid. This is again a primary ICH, not a vascular cause of it. It primarily affects the distal cortical vessels, and the pathology here is the deposition of this amyloid protein in the tunica media, and the tunica media being the strength and compliance layer of the arterial wall. means that when this amyloid protein is deposited there, the vessel compliance goes down. This makes it prone to hemorrhage, and this causes predominantly lobar hemorrhages, lobar in location. And these hemorrhages can often be recurrent and maybe multifocal. So those are kind of the hallmarks of cerebral amyloid compared to other etiologies of ICH. And if you look at, for instance, a gradient echo sequence in the top right, you'll see these clinically silent cortical microhemorrhages, innumerable small hemorrhages. Again, very, very kind of pathognomonic for cerebral amyloid. And then looking at the microscopy, apple green birefringence, unpolarized microscopy is kind of the board's thing that you should know. So the other major category of primary ICH is hypertensive ICH. This differs in location, typically subcortical, predominantly found in the basal ganglia, as well as the thalamus, cerebellum, and the pons. Pathogenesis also differs. It's due to atherosclerosis. This, however, similarly affects the tunica media, again, that strength and compliance layer. And over time, the atherosclerosis leads to weakening of that, loss of that layer and weakening of that layer, which leads to brittle vessels, which are prone to hemorrhage. So looking at, what predicts clinical outcome after a primary ICH event, it turns out that really the major factor is hemorrhage volume. It's striking, a hemorrhage over 60 cc's, we're talking about 90% mortality. And even when you lower that cutoff to 30 cc's, at 30 days, only 1% of these patients are functional. So really, the size of the hemorrhage is very, very strongly correlated to the clinical recovery of the patient, as you might expect. There's also this spot sign that we hear about, we read about, and the neurologists and radiologists love to talk about it. I think we look for it less in neurosurgery, but it is indeed a very strong predictor of hematoma expansion, and it's basically a sign of contrast extravasation and active hemorrhage. So some groups have looked at trying to predict outcome after ICH, just like what I was talking about. And I would say the most commonly used grading system or predictive algorithm that people have used is this ICH score. It's used commonly in neurology. We use it less in neurosurgery, but it's definitely a useful thing to think about. And the basic premise is that a higher score on this scale means a higher risk of mortality. And I won't go through each of the categories, but the basic thing to think about is just conceptually is that the patient will have a poor prognosis if the hemorrhage is large, if the hemorrhage is infratentorial in location, if there's intraventricular hemorrhage, if the patient is old, and if they have a poor initial exam. So these are all kind of logical, and that's kind of how I learned better than just memorizing a grading scale, just to think logically about what would lead to a poor prognosis. And even if we're not calculating these for all of our patients, it's important to consider what are the predictors of a poor outcome. So the management of primary ICH is predominantly medical, and I'll talk in a bit about our involvement in these patients, but it's important to understand the medical management. It was initially, just some historical perspective, it was initially thought that the hemorrhage progressed and completed within minutes. So it was a very short course of hemorrhage, and then it was done. There was no, the acute period was over in a matter of minutes. However, some folks noticed that patients were deteriorating in delayed fashion. And this was correlated on CT to expansion of the hematoma much later than just the short minute-long period that was initially thought. And so around the 1980s, medical management of these patients transitioned to being more focused on aggressive treatment in the early post-hemorrhage period, so the first few days, and really focusing on things like blood pressure management, correction of coagulopathy, because again, it's not just an event that happens and then completes, it is truly a several hour and days long event of where the hematoma needs to be managed. So looking at blood pressure, this is a discussion that I've had with a number of the neurology residents and attendings, and I've never gotten a great answer. So looking a little bit at the data and kind of maybe why it's kind of not definitive what blood pressure goal should be. There have been several trials on this, mainly the INTERACT and the ATTACH trials. Initially, the INTERACT trials showed that there was a trend, not statistically significant, but a trend towards improved outcomes with the systolic blood pressure goal of less than 140 compared to less than 180, so better with more aggressive blood pressure management. ATTACH kind of took a different spin, and they looked at patients who presented with very severe hypertension with a systolic blood pressure greater than 220. And they found there was a significantly worse outcome with aggressive blood pressure control. And, again, it's very significant, 67% versus 29% death or severe disability. Attached 2 dove a little bit deeper and looked at specifically the fact that there were higher renal adverse events with a very aggressive blood pressure target of less than 110 versus less than 140, but no difference in morbidity and mortality. So basically, it's useful to have moderate blood pressure control, but there are risks with aggressively correcting blood pressure control, with aggressively controlling blood pressure, and specifically that manifests itself in renal adverse events. Looking at a little bit of transfusion, some people have proposed that empiric transfusion of things like platelets or TXA or other blood products may help these patients, but it turns out really not much data is there to support it. In fact, the PATCH trial showed that there's higher morbidity and mortality with empiric platelet transfusion, so that is not routinely done. TXA similarly has not shown any significant benefit for these patients. And other trials for platelet transfusion, PCC transfusion, FFP transfusion, nothing has really shown anything worth, with any clinical benefit. Recombinant factor 7A has shown a benefit, but only if given within the first 3 hours of onset. I personally haven't seen this used very much. So now to what kind of matters for this audience, what's the role for neurosurgery in these patients? We know that medical management is the mainstay of treatment, but there's definitely, as we know, a role for neurosurgery. So let's kind of look at that for a second. Obviously, acute hydrocephalus is a complication for many of these patients. In fact, about 23% of patients with primary ICH develop acute hydrocephalus, and that number goes up to 55% if they additionally have intraventricular hemorrhage. And obviously, our role in these patients is usually EVD placement for symptomatic hydrocephalus. I'll take a brief aside and talk about some work that's been done in our department for improving this process. This was mainly the work of Ian Cahigas, as well as med student Henry Chang for spearheading this. But Ian's idea was that so much time is wasted in the emergency department collecting supplies and preparing the patient for the procedure, and these patients are often very sick. They have acute hydrocephalus and need their treatment expedited, and the sooner you get the EVD in, the sooner you get a repeat scan, the sooner they get to the ICU. And so he really wanted to make this process as streamlined as possible, and so his idea was to develop this kind of crash cart or code cart, whatever you want to call it, for EVDs, and all of the necessary supplies for the EVD. He stocked into this labeled cart, developed a system for it being restocked by the staff there, placed it in ERB. And I think we're now at the point where all of the junior residents assume that this is how it always was. But I think I was probably one of the early years where it was kind of new. And before that, I remember, like in my sub-I as an intern, collecting all the supplies was an absolute nightmare. So we're spoiled now. We have this excellent cart in the emergency department, which helps expedite EVD placement. And we wrote this up recently, and actually there's been a 27% decrease in EVD placement times, as well as a trend towards improved clinical outcomes. We also took it another step further. We developed an alert system, so almost like a stroke alert for patients who need an EVD. We called it the Evd Alert. And basically it was a page that went out to all the necessary teams, and automatically for patients who presented with, for instance, subarachnoid hemorrhage or acute hydrocephalus, who were likely to need an EVD, it automatically set into motion the process for EVD placement. So the cart was brought to the bedside, the patient was moved to a location in the emergency department amenable to EVD placement. Stat labs were drawn immediately, automatically, and sent to lab in stat fashion, and a variety of other small things to expedite that process. And again, this showed an additional 30% decrease in EVD placement time. So just want to talk about a little bit of work that's been done in our department to expedite this process, and we're seeing good results from it. So back to neurosurgical management of patients with primary ICH. Hematoma evacuation has been theorized as a possible benefit for these patients, and the idea is that the hematoma itself is toxic and inflammatory to the surrounding brain tissue, and it has been theorized that maybe removing the hematoma would improve patient outcomes, and several clinical trials have looked at this. So I won't go into nitty-gritty detail, but it is important to know these trials and kind of the time course and the time progression of our management of these patients. One of the early trials is the Stitch trial, looked at over 1,000 patients, compared early surgery for hematoma evacuation versus conservative, just medical management, and they found no difference in favorable outcome. So the next iteration was Stitch 2, and they thought that maybe by narrowing the inclusion criteria that they would show a benefit, but even narrowing it to patients with a generally, a better GCS, better presenting exam, superficial supranatorial hemorrhages without IVH, still no benefit was detected. So then other groups thought, well, maybe if we make the evacuation as minimally invasive as possible, maybe that will help, identify a benefit. So the Misty Trials 1, 2, and 3, the technique here was a stereotactic catheter that's placed into the hematoma, drains the hematoma, and infuses recombinant TBA so that the hematoma kind of liquefies and is drained. They found similar mortality compared to controls and no improvement in functional outcome at 1 year. So moving on to Enrich, so similar idea. The thought here is that, again, a more minimally invasive way to evacuate the hematoma may help. In the Enrich trial, they're using brain path, a minimally invasive drainage port to evacuate the hematoma, and more narrow inclusion criteria, and this trial is ongoing. But so far, there's been no clear definitive evidence that hematoma evacuation significantly benefits patients in many cases. Obviously, for patients who have acute decompensation, need emergent evacuation, are actively herniating, that's a different discussion. But for patients with ICH, neurosurgery for hematoma evacuation is still being evaluated, but not definitive benefit. So let's move on to subarachnoid hemorrhage, clearly a neurosurgical pathology and something that we encounter on a very regular basis. So subarachnoid hemorrhage, as I mentioned earlier, about 3 to 5% of all strokes. So not a high percentage, but clearly a high morbidity, mortality, and obviously very close to our neurosurgical world. Average age around the mid-50s. The etiology of subarachnoid hemorrhage is almost always due to an aneurysmal rupture, and mortality is around 50%. So I gave my talk last year on risk factors for aneurysmal development and subarachnoid hemorrhage, so I won't rehash all that, but it is important to kind of just appreciate things that, the factors that go into risk for aneurysmal development. We all know that size, especially size greater than 7 millimeters, has been shown to be important predictor of subarachnoid hemorrhage, and location as well. Typically, it's thought that posterior fossa or posterior circulation, as well as posterior communicating artery and anterior communicating artery aneurysms are more likely to rupture than, for instance, MCA and ICA aneurysms. Other risk factors: age, hypertension, prior hemorrhage, smoking, family history, and morphology have all been evaluated. And more than just morphology, people are looking at actually the flow dynamics of aneurysm development. Again, this is from my talk last year, and people are looking much more deeply at the actual hemodynamics of aneurysm development to identify which aneurysms are most likely to rupture. So a lot of research going into that, and I won't rehash that. So back to the clinical presentation of subarachnoid hemorrhage, the quote-unquote worst headache of life, or quote-unquote thunderclap headache, is the classic description, and we see it all the time. It's not just a step 1 question. Nuchal rigidity, depressed level of consciousness, these are the most common ways the subarachnoid hemorrhage presents. In terms of clinical assessment on presentation, by far the most commonly used kind of clinical grading scale is the Hunt and Hess scale. I'll dive deeper into the origins and the meaning of the Hunt Hess scale in a little bit, but suffice it to say that increasing grade from 1 to 5 is basically decreasing level of consciousness, and that's the main feature of the Hunt and Hess scale. And this helps predict surgical risk, as well as it's also used for identifying which patients may benefit from an EVD, and it turns out that it does also correlate to mortality in these patients. The WFNS scale is a similar clinical grading scale that you may come across. So acute management, as we know, strict blood pressure control is probably the most important thing in the acute setting for an unsecured a ruptured aneurysm, blood pressure control, typically we maintain it less than 120 or 130 systolic. And placement of an EVD, this is for patients typically with a HUN-HES 3 or higher. It's important to appreciate that there's a theoretical risk of rehemorrhage with EVD placement. This is controversial, but some people think that the transmural pressure across the aneurysm sac, the aneurysm dome, increases when the brain and the ventricular system are decompressed. And this is theoretically been hypothesized to increase the risk of rehemorrhage. So our practice is to keep the EVD high, usually at a level of 20, and to minimize this risk. Keppra is given for seizure prophylaxis, nimodipine for protection against delayed cerebral ischemia, and further imaging studies to evaluate for the source of the hemorrhage and the presumed aneurysm when they present like this. So kind of a important discussion of the history of when the neurosurgeons have intervened for subarachnoid hemorrhage and for ruptured aneurysm. So historically, the idea was that the major risk for these patients, and this is true, is that there is a re-rupture event in the immediate post-hemorrhage period. And so the thought was that surgery must be performed as soon as possible in order to minimize that risk of re-rupture. And this re-rupture risk is highest within the first 48 hours. So surgeons were willing to assume, whatever high surgical risks are associated with very sick patients with high-grade hemorrhages, in order to protect the patient and secure the aneurysm and protect the patient from a repeat rupture. Then folks noticed that the surgical risk of these procedures was extremely high for these acutely ruptured high-grade subarachnoid hemorrhages. And so practice transitioned a little bit to performing delayed surgery. So waiting until the brain cooled off and the patient was more stable for surgery to secure the aneurysm. While yes, the morbidity and mortality from surgery may have gone down by delaying surgery, you then have to appreciate the risk of rehemorrhage, that you're leaving the aneurysm unsecured in the most critical period, and the period when it's most likely to re-rupture. And this is this red, angry, swollen brain that Dr. Hiros talks about, that we've read about. And this is basically the thought is that this is the source of the high surgical risk for early surgery for aneurysms. But it wasn't appreciated until later which patients had the highest surgical risk, were most likely to have this red, angry, swollen brain. So the HUN-HES scale is really the key here. And the idea is, back in the 60s, the idea is that a higher grade on the HUN-HES scale, so basically a lower level of consciousness, is correlated with higher risk of acute surgical intervention. It's basically a proxy for the degree of red, angry, swollenness of the brain. So the poorer the grade on admission, the poorer the clinical presentation, the more likely that patient is going to have high surgical risk and a very swollen brain, not amenable to early surgical intervention. Importantly, the HUN-HES scale should be calculated after correction of reversible causes. So if the patient comes in seizing with acute hydrocephalus, that exam may not reflect their true HUN-HES scale. So that's something to keep in mind that we often forget. But basically, the key takeaway from the HUN-HES scale, even though we use it all the time, it's important to remember its origins and the fact that it's used to correlate clinical presentation with the risk of acute surgery. This international cooperative study was done in the 80s and 90s to actually study this specifically. It was a prospective observational trial. They found that there was many findings. I'll highlight the interesting ones. The main thing is that they found no difference in outcome between early or late surgery. And this is taking all patients, all grades. And looking at that data as a whole, you would conclude that the perioperative risks of early surgery are basically equivalent to the risk of rebleeding in patients who undergo delayed surgery, right? So it's assuming which risk do you want to assume. But if you look closely at their data, the patients that were drowsy on admission, so basically translating that to HUN-HES, that's a HUN-HES of 3, 4, or 5, had a very high morbidity, a mortality rather, when operated on early, before day 11, but much lower if operated late. So again, this validates kind of what the HUN-HES scale was hinting at, that the surgical morbidity is lower, as we know, once it cools off. But perhaps certain patients, right, the higher grade aneurysms have a higher surgical risk for acute intervention. So kind of to sum this up in a timeline, in the early period, there's high surgical risk, red, angry, swollen brain. These are the grade 4 and grade 5 Hunt-Hess subarachnoid hemorrhages. However, intervening early minimizes the risk of rehemorrhage because that high risk period, this first 48 hours are the most common period for a re-rupture. In the middle period, there's vasospasm risk. I'll talk about that in a second. Still fairly high surgical risk, still a red, angry, swollen brain, and an intermediate rehemorrhage risk, right? You're operating not super early, but not super late. In the late period, high rehemorrhage risk. You're letting that aneurysm remain unsecured for the most critical period. However, the surgical risk is lower. So in summary, high Hunt-Hess grade, very angry, swollen brain, poor surgical candidate in the acute setting. So you may be more willing to accept the risk of rehemorrhage and delay treatment to when surgery is safer. Low Hunt-Hess grade, low surgical risk, early surgery doesn't carry an exceedingly high risk due to the fact that the brain is less swollen than the high grade patients. Therefore, early surgery is typically favored. So looking at the treatment of aneurysms, microsurgical management of these aneurysms was always the mainstay until the endovascular world started. Early management of these aneurysms was Imperian ligation, which was adapted for treatment of cervical carotid aneurysms. In the 20th century, new techniques such as wrapping, packing, and trapping were developed, and ultimately clipping became the mainstay of microsurgical treatment of aneurysms in the 20th century. Cerebral angiography, this is the new has been the new frontier of aneurysm treatment since it was first done in the 1920s and has gone through many iterations of guiding these catheters up to the cerebral circulation, initially by blood flow, magnets, and ultimately developed these microcatheters and guide wires that we use today were developed. Early embolic agents were very creative. They used things like hog hair and shotgun pellets, and as we know, that's evolved significantly since then. And detachable balloon embolization was also a big breakthrough in the 20th century. So modern endovascular therapy, I'll just kind of briefly go over some, the mainstays, the Guglielmi coils. These were developed in the 1990s and were a major breakthrough. And these remain a mainstay of endovascular treatment of many aneurysms. This diagram here is actually the initial kind of diagrams that were used to develop these. There are other things like the pipeline embolization device. The idea is flow diversion diverts blood flow away from the aneurysm sac and through the parent vessel so that the aneurysm sac can thrombose. And these stents are, the idea of flow diversion is that perforating vessels off of the parent artery remain perfused if there's high flow through those branches. And there are a number of other technologies. There are intrasaccular devices and many more. I think Dr. Stark gave a talk on these technologies in recent years. So this is a topic for another grand rounds. Going back to our discussion of the timing of surgery, endovascular is a major breakthrough especially for high-grade patients, because you can imagine that you avoid the discussion of operating early for these high-grade aneurysms when the brain is so angry and swollen. And by treating them endovascularly, you don't have to assume that high surgical risk, and you can secure the patients early, minimizing the risk of rehemorrhage. So the never-ending discussion of open versus endovascular treatment for aneurysms is obviously a very dynamic world as technology changes and as practice patterns change. But it is important to know a little bit about the history and the major trials that are kind of the foundation of our understanding. ISAT, a very controversial and older trial, but important to know. So over 2,000 patients were included in the trial, and this was almost all outside of the US. Their findings, if you just look on face value, coiling had a higher rate of rehemorrhage, but a higher rate of disability-free survival at 1 year. So clinically, these patients in their study did better than patients who underwent clipping. At 10 years, the coiling group was also more likely to be alive and independent. However, significant limitations to this study. It was all outside the US, so hard to say how generalizable it is to hear. Selection bias was also a problem. About 80% of the cases, actually, the surgeon had a preferred modality to use. So was there really clinical equipoise for these patients? In looking at the cases that were excluded from the trial and not randomized, they were clipped more than coiled. So what does that say about the cases that were selected and included? Also, the generalizability here is questionable. Most of the aneurysms were small anterior communicating artery and posterior communicating artery aneurysms. So again, these results may not translate to aneurysms in other locations or to larger aneurysms. And perhaps most importantly, this study was done in the 90s, and the endovascular treatment and techniques and technology today are a world away from what existed back then. So again, it may not be generalizable to what we have to offer these days. The Vera ruptured aneurysm trial is another similar study that tried to compare clipping to coiling. It was a prospective trial, 500 patients who are randomized to coiling or clipping. They found that coiling had a lower rate of complete occlusion angiographically, but even with that, there were no cases of re-rupture at 6 years. They found that coiling demonstrated a better outcome for posterior circulation aneurysms, but for the anterior circulation, outcomes were similar. And here's their data there. So a little bit more of a nuanced analysis and interpretation of their results. Just to round out the discussion of subarachnoid hemorrhage, no discussion of aneurysms is complete without a discussion of vasospasm. This is, simply put, vasoconstriction of the intracranial vessels when exposed to subarachnoid hemorrhage. The high-risk period is between days 4 and 14. We use transcranial Dopplers to screen for elevated flow, and that suggests vasospasm. Patients are given nimodipine. This reduces the risk of secondary ischemia and poor clinical outcome. Although historically there were discussions of hypervolemia, hemodilution, now the practice is normal volemia. And in terms of blood pressure, it's usually permissive or induced hypertension in patients who develop vasospasm. There's really one main scale that's used to grade subarachnoid blood, and that's designed, it's a Fisher scale, and it was designed to basically correlate the radiographic evidence of subarachnoid blood and vasospasm. So there's a traditional Fisher scale and a modified Fisher scale, but suffice to say that the more subarachnoid blood you have, the higher your risk of vasospasm. And this is intuitive, right? The more blood there is to irritate the vessels, the more likely they are to go into spasm. And finally, for subarachnoid hemorrhage, we know that hydrocephalus is a common complication or a common part of patients with subarachnoid hemorrhage. For delayed hydrocephalus, shunts are often needed to be placed. And in fact, 16% of patients who have an EVD placed during their subarachnoid hemorrhage admission will ultimately require a shunt. Risk factors for developing hydrocephalus, intraventricular hemorrhage, higher Hun-Hess grade, and higher Fisher scale. And seizures, these occur in about 10 to 20% of these patients. Risk factors are higher age, history of prior seizure, anterior circulation aneurysms, as well as hydrocephalus. And we routinely give Keppra for prophylaxis. So moving on to AVMs as the other major category of sources of hemorrhagic stroke, at least in the neurosurgery world. A bit of epidemiology, not the most common lesions, 0.02 to 0.2% prevalence. However, despite that low number, they're responsible for 38% of intracerebral hemorrhage in the young population, so ages 15 to 45, talking about 38%. It's thought that they are developmental. However, there have been some groups that have proposed that they can be acquired, for instance, through venous hypertension. But for the most part, they're thought to be developmental. In terms of the natural history, intracerebral hemorrhage is the most common presentation, 45 to 72%. They can also present with seizures. The location of the hemorrhage, most often intracerebral or intraparenchymal. However, intraventricular hemorrhage and subarachnoid hemorrhage can also be associated with AVM rupture. A rupture event carries about a 20% mortality, and then among the survivors, an additional 20% are left with permanent disability. So very high morbidity disease. And the natural history is poorly understood because most studies are limited by early treatment, and these lesions, because they have a high risk for hemorrhage, are usually treated, and so we don't have a great understanding of the natural history. Within those limitations, this is what we know. About a 2 to 4% annual rupture risk is the way to think about it. However, if the patient's had a prior hemorrhage from the AVM, that number goes up to about 4 to 11%. Some groups have proposed a kind of a shortcut way of calculating the patient's lifetime rupture risk, which is 105 minus the patient's age. And so, these often affect young patients, and it's important to think about, adding up that annual rupture risk over the many years that they may have to live, especially if you're talking about, a teenager or a 30-year-old. And so the 105 calculation is a rough way to kind of think about it. Risk factors for AVM rupture. So size, this is very controversial. Some groups have suggested that small AVMs actually have a higher rupture risk, and they've theorized that it's due to higher feeding artery pressure. However, other groups have shown higher risk for larger AVMs. The reality is it's very hard to calculate this. We don't know what the denominator is, and we don't know what the prevalence of small or large AVMs is, and it's very, very difficult to say. So I would say it's inconclusive whether or not size matters for risk of hemorrhage for an AVM. Location, some folks have shown that deep location and deep venous drainage are risk factors for hemorrhage, and that infragentorial AVMs may be at higher risk. Younger patients and previous rupture have been shown in some studies to be risk factors for AVM rupture. And lastly, aneurysms, which, it can be difficult to identify the source of the hemorrhage, whether it's the AVM or the aneurysm. But those are also considered a risk factor for hemorrhage. And the other complicating factor with identifying the importance of aneurysms is, well, the more complex AVMs are more likely to have aneurysms. So maybe that's a confounding variable in terms of identifying what's responsible for a higher hemorrhage risk. Prognosis for these patients tend to be better after AVM rupture than aneurysmal subarachnoid hemorrhage. There are several theories for this. Some people think it's because AVMs affect younger patients typically. The other idea is that, well, the brain within the AVM, kind of nidus is not functional brain, so the hemorrhage is less likely to affect eloquent parenchyma. The other thought is that vasospasm, which is a significant source of morbidity for patients with ruptured aneurysms, is much less likely with AVMs. And so maybe that accounts for the difference in prognosis for these lesions. We talked about the ICH score, and the ICH score was developed to predict outcome for any cause of ICH, specifically 30-day mortality. However, it's really not specific to AVM, so it's hard to say if it's the best way to predict prognosis. There's one study out there. They developed an AV ICH score, so AVM basically ICH score, and added a couple modifiers to make it more predictive. However, it's a little bit lengthy and complicated to calculate. So no real great ways to estimate prognosis for these patients. Some of my research has been looking at this as well. A couple years ago, we developed the Ruptured AVM grading scale, and the idea is that these existing grading scales are not specific to AVMs, and the ones that are very complicated to calculate. So how do we, for a patient who presents clinically with a ruptured AVM, how do we predict the prognosis? And our approach was all comers, so blind, regardless of how the patient is treated, just looking at almost how the Hunt-Hess scale is used, right, to estimate the clinical outcome, even though it's not what it was designed for. Kind of thinking about it that way. Patient comes in, what is the prognosis for this patient purely based on their presenting characteristics? And we developed this score. It basically is based on the Hunt-Hess score. So we all kind of think in that language of the Hunt-Hess score based on their presenting exam. So 1 to 5 are the Hunt-Hess score. Age, 1 point if their age is greater than 35, an additional point if their age is greater than 70, and then 1 point each for deep venous drainage and eloquence. And these are, again, familiar to practitioners. They're part of the Spezza-Martin scale and all available for a patient who presents with a ruptured AVM. And importantly, even though it's an all-comers approach, but in subgroup analysis, we've shown that it's accurate in predicting outcome for both treated and untreated lesions, as well as pediatric and adult patients. So it was developed basically with serial ordinal regression. We distilled it down to the simplest model, just those 5 categories that I just mentioned. And it turns out that even with just those simple categories, it outperforms all other commonly used grading scales. So a lot of numbers there at the bottom, but suffice it to say that the area under the receiver operating curve is highest for the RAG score compared to the other commonly used scores, ICH score, Spezza-Martin, or even just the simple Hunt and Hess score. Importantly, it's quick to calculate, it's easy to implement. We've now done subsequent studies validating it on external cohorts, and we found that it reliably estimates prognosis with a higher accuracy, higher predictive value than other grading scales. And another way to think about it is this is a way to benchmark interventional results. So this is basically saying this is the expected history or expected clinical outcome of this patient who presents with this particular exam and AVM characteristics. And you can compare the results of either a particular group or person's interventions with what is the expected kind of recovery for a patient with this particular RAG score. And so that's another way to think about the RAG score. Here's just kind of visually just demonstrating the red bars are good clinical outcomes, so MRS 0 to 2. The blue bars are poor clinical outcome, so MRS 3 to 6. And as you can see, just kind of visually, the RAG score differentiates, the RAG scores on the bottom. Higher RAG score really better differentiates the good and poor functional outcomes compared to Hunt and Hess and Spezza-Martin, these other grading scales. Another way to look at it is here is increasing RAG score on the bottom, and then the likelihood of good functional outcome. And really 6 seems to be the cutoff. If you're 5 or less, pretty good chance that you're gonna end up at a modified Rankin score of 2 or less. So really functionally independent, whereas 6 or higher, much less likely to have a good recovery. And we found that it holds true for both pediatric and adult patients and treated and untreated AVM. So again, an all-comers approach to think about clinical presentation and AVM characteristics for predicting functional outcome. Lots of ongoing follow-up studies to this going on, and we'll see where it ends up. So management of AVMs, the early risk of rehemorrhage is lower than for aneurysms. So the decision algorithm is a little different than what I talked about for aneurysms. Typically, surgery is delayed until after the initial recovery period. So this means that there's less edema from the initial hemorrhage event. The hematoma liquefies, which can facilitate identifying and resecting the AVM. And it also allows for the patient to recover neurologically and understand what their kind of new baseline is after the hemorrhage, and kind of have that discussion of risks and benefits of surgery with the family once you know what their natural recovery from the hemorrhage is before you tackle the AVM. And even for patients requiring emergent hematoma evacuation, the treatment of the AVM is typically different in most cases. So kind of pictorially, I'll go through this. So the initial hemorrhage event, basic things, stabilizing the patient, blood pressure control. And surgery is really only done in the acute setting, in most cases, for emergent hematoma evacuation. If there's acute hydrocephalus, again, these AVMs can often cause intraventricular hemorrhage, management of the hydrocephalus with an EVD or whatever is indicated. In terms of recovery period, as I said, you typically want to see the patient recover and see what their new baseline is before having the discussion of risks and benefits with the family of operating. This also allows, as I said, the hematoma to liquefy, the edema to improve, and allows for our prognostication of the patient's outcome to be better informed. And finally, the treatment of the lesion, of the AVM, which I'll go through now. Conservative medical management, surgery, radiosurgery, embolization, or a combination of the above. So, way to think about this is kind of similar to aneurysms, but a little bit different. It's about weighing the lifetime hemorrhage risk, especially in patients. A lot of these are young, and with a 2 to 4% annual hemorrhage risk, it's a very real number, with the risk of surgery. And so it's all about a risk-benefit analysis. And the factors that influence hemorrhage risk are different than the factors that influence surgical risk. So you have to consider those separately. And the decision of how to manage the patient is balancing the risk of surgery with balancing the risk of future rupture. So the Spezza-Martin scale, which we all know and we're familiar with, looks at the size of the AVM, the location of the AVM, whether or not it's an eloquent tissue or not, and then the venous drainage, whether or not it's deep. This basically is designed to address the question I was just getting at, right? What is the risk of surgery? And the Spezza-Martin scale, we've learned, estimates the surgical risk, and a higher grade, typically Spezza-Martin 4 or 5. These are AVMs that carry a very high surgical risk, And whereas the lower Spencer-Martin scale, lower Spencer-Martin grade AVMs are more amenable to surgery because they're a lower risk. So kind of, this is, again, it's a balancing act. If you think about a low-grade lesion, so Spencer-Martin low-grade means the surgery is carries less morbidity than a higher risk, higher grade lesion. In a young patient, so high lifetime rupture risk with a prior rupture, again, higher lifetime rupture risk. This cost-benefit analysis would favor surgery, right? Surgery is lower risk, whereas there's a high lifetime risk of rupture. But then think about a high-grade lesion with high surgical risk in an older patient with no prior rupture. In this case, you'd probably favor, it probably favors not doing surgery. So no discussion of AVMs is complete without discussion of the Aruba trial, which we've all heard about many times. So I'll kind of distill it down to what matters. And I know it's obviously very controversial, but it's important to know why. So the Aruba trial compared intervention for AVMs with medical management. Looking at their results on face value, they found a 30% risk of stroke or death in the intervention group compared to just 10% in the medical group. The study was stopped prematurely, as after about 200 patients, and mainly were the grade 3 and 4 lesions that had the major differences. A whole host of limitations to the trial, and the reason why it's so controversial. One thing is the fact that the study had a 5-year follow-up, and the thought is that this is too short to capture the long-term risks and benefits of intervening for an AVM. By doing surgery, by treating an AVM, you're assuming all that risk now at this particular moment, and that is with the goal of limiting the risk of or decreasing the risk of hemorrhage over the lifetime of the patient. It's hard to truly capture that benefit if you're just looking at a 5-year follow-up. Importantly, for the patients that were included, the most common treatment was embolization for cure, and there was only a 40% complete obliteration. And we now know that, or we know that partial obliteration of an AVM can actually increase the rupture risks. And so it's not, the study didn't manage these patients as is kind of standard of care now. And so that's why the generalizability and the ability to interpret it in the context of today is a little bit hard. Their inclusion criteria were also broad, so very high and very low risk lesions were included. A couple of follow-up studies have kind of taken the inclusion criteria for Aruba and applied them to other patient groups. So a couple of them basically show for low-grade lesions when taken to surgery, very low mortality, very low morbidity, and a very high rate of obliteration. So the takeaway is if you select the right patients, especially low-grade, Spencer-Martin AVMs, surgery can lead to high obliteration, certainly higher than they had in their study, with low morbidity and mortality. So going through the treatment options one by one, microsurgical resection is a mainstay of treatment. As we talked about, the Spencer-Martin scale is a way to estimate the risks of surgery. Higher grade lesions have a higher risk of surgery, whereas low grade lesions are lower risk and typically favor surgery. Key principles, and other people in this department are much more equipped to discuss this than me, but major principles for AVM resection: you want a wide exposure, you want to preserve the draining vein until the very end. You also want to preserve the en passage vessels that are feeding normal tissue, and you want to visualize the loss of the arterialized appearance of the draining veins. Intraoperative angiography is often used to confirm complete removal of the AVM, and angiographic cure is achieved in at least 90% of these cases. So other options for AVMs: radiosurgery. This is particularly good for small, eloquent, and deep AVMs. Larger size of AVM is associated with lower obliteration rates. The major disadvantage of radiosurgery is that it's not an immediate treatment. So whereas for microsurgery, you resect the AVM, you see immediately on the intraoperative angiography that the AVM is gone, and the hemorrhage risk is basically, from the AVM is done. Radiosurgery takes many months or even years to actually obliterate the AVM. And so there's a period where there still is a hemorrhage risk. So that's really the major limitation of it. There's also a risk of radiation-induced changes, as we know from any type of radiosurgery. Numbers are variable out there, but somewhere around 65% obliteration rate, and but annual post-radiosurgery hemorrhage rate around 1%. Embolization, so can split it up into partial and curative. Partial embolization is not necessarily not very common. Mostly it's for high risk features. So for instance, to decrease flow in a high flow AVM. And as I mentioned, partial embolization is actually associated with higher hemorrhage rates. So not something that you want to do with an intent to treat the AVM, because you could actually increase the rate of hemorrhage. Curative embolization, it's been shown to be a higher likelihood of obliterating the AVM completely if the AVM is small and low grade. And this is best for patients with a particularly high individual surgical risk, or AVMs that are particularly difficult to access surgically. In terms of neoadjuvant embolization, it's commonly done in a pre-surgical fashion. So for instance, embolization of feeders that are difficult to access in surgery. And the major objection is to make the surgery safer. We talked about the importance of preserving the draining vein. You can imagine if the arterial feeders are deep in the surgical, from the surgical approach, and if you need to save that draining vein for last, and let's say the drain is superficial, it's important to perhaps embolize those arterial feeders that are deep and difficult to access in order to increase the safety of the resection. Embolization of perinatal aneurysms is also one way that preoperative embolization is used. And the major thing is you want to weigh the risk of embolization, which is not benign. It's still an added procedure with added risk, with the benefits of the embolization to the surgical resection to assess whether it's worth it. Pre-radiation embolization is controversial, and the idea is that it may decrease the size and the flow of the aneurysm and improve obliteration rates. But the data generally has shown that that it actually decreases obliteration rates. So it's not used routinely, and there's very little evidence to suggest that it actually decreases the rate of hemorrhage in that kind of in-between period between when you radiate the lesion and it's actually obliterated. So without that benefit, which is not very clear, it's not commonly used. I'll briefly, to wrap up the talk, go through some the myriad of other causes of intracerebral hemorrhage that are important to neurosurgeons. So Moyamoya disease, this is progressive stenosis of the carotid circulation. There's a peak during childhood around age 5, and then another kind of mid-40s peak in terms of the epidemiology. The pathogenesis of this is basically as the carotid progressively stenoses, collateral vessels develop to maintain perfusion of the brain, and these collateral vessels are very fragile and therefore at risk of hemorrhage. Hemorrhagic presentation is more common in adults, and there's a Suzuki grading system on the bottom right that basically grades the degree of stenosis and collaterals. Surgical treatment is with bypass, either direct or indirect. Dural AV fistulas, these are anomalous connections between arteries and typically a venous sinus. There's different types with increasing risk of hemorrhage to the patient. So the most straightforward and the lowest, the most benign type is a direct connection to a venous sinus with anterograde flow. Over time, these the venous sinus can arterialize and stenose, and this then leads to reflux and retrograde flow of the fistula. And this becomes dangerous when that retrograde when that reflux goes into cortical veins, because once that reflux is in cortical veins, this high flow arterial pressure into fragile veins of the cortex can cause hemorrhage, and that's when these lesions become problematic. And then more recently, Zipfel and colleagues kind of identified the fact that symptomatology is important for predicting hemorrhage as well. So not just is it the angiographic characteristics of the fistula, but for patients who present symptomatically, they showed that there's a much higher risk of hemorrhage as well. So the main takeaways: cortical venous reflux and symptomatic presentation are the major risk factors for hemorrhage of a dural AV fistula. Cavernous malformations, incidence around 0.4 or 0.5%. These are often incidental, but can cause seizure or neurologic symptoms. The hemorrhages are typically small and typically within the lesion itself. These hemorrhage at a rate of about 0.5 per year, but the rate can be higher if there's been a previous rupture of the lesion, and it in fact can exceed 20% in the immediate post-hemorrhage period. These are associated with developmental venous anomalies, which drain normal vein and are important to preserve during surgery. These can be sporadic or familiar. Management is with surgery or observations or observation. Symptomatic lesions in safe locations are often treated surgically. And as I said, it's very important to preserve that developmental mutinous anomaly because it drains normal brain and is not part of the cavernoma itself. And as similar to with AVMs, it's common to delay surgery after a few days so that the hematoma liquefies. So just to wrap up, again, Josh talked about ischemic stroke recently, and he talked about a lot of the improvements that have been made in managing these patients. And it seems like every year there's a host of new trials that show more indications for mechanical thrombectomy and ways to improve care. And the data supports the fact that our management of ischemic stroke has led to improvements in patient care. However, the same is not true of hemorrhagic stroke, and not much has changed in terms of our ability to care for patients and patient prognosis. So there's a long way to go, and I hope that that our research can help improve the care of these patients, and that we can kind of catch up to the ischemic stroke world. So that's all I have, and I'm happy to answer any questions.